Williams from Tapion Hospital in St. Lucia. And the topic of their presentation is Management of Snakebite Envenoming in St. Lucia. Welcome, colleagues.
Good afternoon, everybody. Thank you for having us, Professor Gutierrez, and being in Costa Rica and Davao. You know, we have a great relationship with our French brothers and sisters, and so we're happy to be here. So thanks for everybody. So I'm going to start off the presentation, and then Dr. Williams is going to go into the core of it. So we're going to do management of snakebite envenomations in St. Lucia. So just want to mention something. This gentleman there, most of us know him. He's a real giant for us. This is Martin Didier. He passed away last year, and he was like my father and my mentor, and also served like that, as that for Davao as well. And he pioneered snakebite management in St. Lucia. He was the go-to guy for all snakebite. Throughout the island, anybody with a snake bite would call him. He was the first and the pioneer of this thing. Anya is going to quote later, cite later, a paper he actually did, similar to the paper that was done on lanceolatus in Martinique, where there were evidence of thromboinflammation and thrombotic events in a young farmer in St. Lucia, and he actually co-authored on that paper as well. So he's really a giant for us, and you know his vision is about succession planning, and that was what he was all about, and that is why he got me on board onto meeting with Davao and going to Martinique and Professor Gutierrez and getting on board with the snakebite management to pass on the baton. So and what I'm doing is exactly what he would want, is to pass on the baton further. And Dr. Williams is now that future with that interest. And she's been doing a lot of great work, And I know Dr. Didier would have been very proud, doing a lot of great work in St. Lucia with the EMTs and the fire service and outreach to the farmers and snakebite management. And she's really taking that bull by the horns right now. So hence why I'm just going to be here for a short and let her take the stage thereafter. So I'll just do a small bit. So just the overview of our presentation. We're going to talk about the epidemiology of snake bites, common venomous species in St. Lucia, typical clinical presentations. We have a few quite interesting ones, similar to one that Jonathan had, and the gaps in our local data and reporting. So snake bites in St. Lucia, it's a small island country in the Caribbean Sea. It's about 24 miles south of Martinique and 21 miles north of St. Vincent. St. Lucia's, our population is 184,900 people. We have two main hospitals, one in the north and one in the south. And 4 main snake species are found on the island, mostly found in rural communities within the rainforest. And for 2025 to date, so far we've only had 4 documented snake bites at the public hospital in the north. So endemic snakes, the boa orpheus, that's the boa constrictor, it's non-venomous, and the St. Lucian racer, that's 2 of our more common snakes, and the pit viter, Bothrops caribeus, which is a cousin of the lanceolatus in Martinique. I'm not sure if Davao would agree, but I think ours came first and evolved into the Martinican one across the water, based on its epidemiology. And yeah, so this is the distribution. So this is a map of St. Lucia. If you see that yellow grid in the middle, that is primarily where the latest information where the snakes are found within the last 5 years. That's mapping from 2020 to 2025, the middle of the island. You see where our hospitals are? Pretty far. So this is more the rainforest, and the hospitals are a pretty good distance. And these are the only 2 places where the antivenom is found. Yeah, at those 2 hospitals. Earlier, before 2020, that purple area on the East Coast is where we would have found some snakes, but these sightings there are getting less and less with population growth and farming and so on. Okay, so now I'll now hand you over to the key speaker today, Dr. Williams. Thank you.
Muchas gracias, Dr. Benjamin. So now I will be looking at, thank you. So our snake, which is venomous snake, which is indigenous to St. Lucia, has a toxin, or the venom is known to be a hemotoxic venom. And so it causes endothelial damage, coagulation factor effects, and platelet dysfunction. This endothelial damage is a result of the increased permeability of those blood vessels, resulting in bleeding and thereafter large hemorrhage. The coagulation factor effects consist of consumption of clotting factors, resulting in coagulopathies with prolonged PT or PTT, and the platelet dysfunction, which is a result of the inhibited platelet activation and aggregation of these platelets, which then now results in microthrombi and tissue ischemia. So immediately when a person is bit by a snake in St. Lucia, we have our emergency management protocol, which would happen wherever that is. So we'd obviously start with our ABC stabilization, making sure that the patient is able to breathe, the airway and circulation is intact, a rapid assessment of the patient, triage, and quick transport to the nearest hospital. We would avoid harmful first aid myths because obviously in St. Lucia there are several myths within the different communities as to what should be done when a person gets bitten by a snake. Whether it is that you should suck the venom out, if you should urinate on the wound, tie the leg. There are so many different things that people come to us saying that they do that they know they're supposed to do when they get bitten by a snake, which is incorrect. And thereafter, obviously, the antivenom therapy. In St. Lucia, we have the polyvalent antivenom, which is manufactured here in Costa Rica. They come in vials of 10 mils and can be used intravenous and intramuscularly. In our setting, more than likely it is intravenous, but it can be used intramuscularly, but there would be special settings for that. It must be stored at 2 to 8 degrees Celsius. So what are some of the benefits of the antivenom? It is obviously a life-saving treatment. It reduces the symptoms. It causes prevention of the long-term complications of the snake bite and improves with the rapid recovery and improved clinical outcome of these patients. In St. Lucia, this is our current regimen as to how we administer the antivenom to our patients. We have 3 classifications from light, moderate, and grave. And as you can see on this, the left side, we have the manifestations. So our local manifestations would include pain, edema, ecchymosis. We have systemic manifestations like hemorrhage, shock, anuria, and vomiting. And obviously, one of the main things that we've been talking about today would be the coagulopathies, which would include clotting, increasing clotting time, and the formation of platelets. So according to these classification, it determines how many vials of antivenom we would give to the patient at the time, considering whatever classification that they fall into. So if it was a light envenomation, the person would receive between 2 to 4 vials of antivenom. Moderate would be between 4 to 8, and grave would be between 8 to 12. Usually when administering antivenom, it is not something that we do quickly. We do take within at least a 20 to 60 minute range while administering. Something else that I should mention, when giving our antivenom, we try to at least give some pre-medication when it comes to probably thinking of the possibility of an allergic reaction, whether it be that we give hydrocortisone, we give Piriton, we also give these pre-meds before administering the antivenom. So like I spoke about earlier, we have in St. Lucia our anti-venom therapy, but in addition to this, we have our supportive care. The hydrocortisone, we also include IV fluids, monitoring of circulation, because like we mentioned earlier, we could have patients that could go into compartment syndrome when it comes to the limbs, breathing support, wound care, antibiotics if necessary, and also tetanus prophylaxis. We have our follow-up rehabilitation in some cases where we have patients who have venom, where the venom has caused local tissue damage or systemic effects that require a long-term care, which would be whether it be wound care, surgical management, and management of their coagulation disorders. So we have 3 cases today that I would like to present to you. The first one is a 12-year-old male who presented to hospital with swelling and pain to the left leg after a suspected snake bite. The local findings were swelling, warmth, tenderness, but no necrosis of the area. His vital signs were stable and had no systemic symptoms. His lab work showed no coagulopathy or rhabdomyolysis, and as an assessment for him, we had him as a mild envenomation, which resulted in him receiving the anti-venom therapy, which would have been between the 2 to 4 vials, analgesia, IV hydrocortisone, IV fluids, and obviously observation. After this, the patient was stable and he was discharged after 2 days with follow-up in 2 weeks at the clinic. So this was a fairly simple case. The second one was a 16-year-old male bitten by a snake while walking near a river. He experienced immediate sharp pain and a rapid onset swelling to the right knee. He developed mild breathing discomfort initially, which then resolved, and then on examination at the hospital was seen swelling, erythema, warmth, no necrosis, and his distal pulses were intact. His vital signs were stable throughout his admission, and upon ultrasound of the limb, it showed subcutaneous edema but no joint effusion. For him, we had a diagnosis of a moderate envenomation with cellulitis to the region, and his management, included the antivenom, as per the protocol, hydrocortisone, IV fluids, antibiotics, cold compress, and elevation of the limb. His outcome, he improved clinically after 7 days. He was able to ambulate and was discharged to home with tapering steroids and to complete 10 days of augmentin. Now, this is one of the most interesting cases that we have experienced in the last couple of years since I have been doing the whole snake bite management so far in my career. It was a 64-year-old male farmer with a history of 3 previous snake bites between 2020 to 2023. He returns now in 2025 with a bite to the right foot while walking through his farm. Upon examination, mild swelling of dorsal right foot, pulses intact, no necrosis, and a GCS of 15/15, and his vitals were stable on arrival. He received the protocol antivenom, then subsequently had an episode of a transient unresponsiveness of approximately 3 minutes. No seizure activity or no incontinence. His lab work showed no coagulopathy, normal renal function, and a mild AST elevation. His CT brain was normal. So as an assessment for him, we were querying whether it was a reaction to the antivenom versus a transient ischemic accident secondary to a thrombotic event. His management was the antivenom therapy that he received, analgesia, cold compress, elevation, monitoring, and he improved after 72 hours and was discharged to home. So the question I pose to you today, what do you think? In this patient, he was bitten by the snake at 6 o'clock in the morning, came to hospital at 4 o'clock, where he received the antivenom, and then he had the unresponsive episode. So it leaves to question was whether it was that he was already receiving the thrombotic effects of the venom versus whether it was because he had just received the antivenom. What if it may have been a reaction to the antivenom? So like Dr. Benjamin mentioned, in 2002, Dr. Didier did a paper on a 32-year-old male who suffered multiple cerebral infarcts after being bitten by a snake. But in this case, we're not quite sure, even if clinically we were able to detect that he did have a transient ischemic accident, what really was the cause of it? So our local challenges in St. Lucia when it comes to snake bites is, one, the limited access to the antivenom, the variation in provider training, and the need for unified national guidelines and geographic delays in care. As you could have seen by our distribution, there is quite a distance between our two main hospitals from the main area where it is that the snakes are more prevalent. However, we have been improving those outcomes in St. Lucia, thankfully, by the initiatives of the government of St. Lucia by creating the universal healthcare coverage when it comes to snake bites. So right now in St. Lucia, anybody who gets bitten by a snake and is treated at any of our hospitals receives the antivenom, the hospital stay, whatever medication, whatever rehabilitation, if they have to have surgery, anything, all of that is now free of charge in St. Lucia. In addition, thanks to the universal healthcare coverage, we have had several roundtable discussions, basically improving the training of our EMT and EMS training in St. Lucia. We've been strengthening our reporting systems because this is also an issue for us. From the documentation that we get at the hospital, sometimes we only get like 4 or 5 cases which are documented, but we know that there are some cases that are not reported and not documented properly. We want to improve the antivenom supply chain, obviously by creating these conferences that we have like today helps to do so, and public education initiatives and training for rural and ER providers. And we also recently had a simulation activity which was actually televised for the nation. So our research and future directions is that we would like to improve our local data collection. Like I mentioned, it is that we have very few documentation, but from word on the street, we know that there are a lot more snake bites in St. Lucia which are not being reported. We want to improve on our regional collaborations like we're obviously doing here today, sharing with other people from other countries who have venomous snakes to figure out what it is that you're doing, what are we doing, and how can we collaborate and share our ideas together. We would like, obviously, to build a national snakebite registry and to continue our community sensitization programs. So in conclusion, snakebite remains a major preventable health threat. Timely intervention saves lives and collaboration is key for improved care. Muchas gracias por invitar a Santa Lucia.
Thank you very much to the colleagues of St. Lucia. We have time for one question or comment. Yes, Hatem.
Thank you very much for this presentation. It is more than one question, but the first is in your gradation system, the grade 1, donc the slight severity envenoming, it is characterized by the absence of local signs, the absence of systemic signs, and presence or absence of coagulopathy. That means that if there is an history of snake bite and patient didn't present any symptom, you consider that he's envenomed and you administer antivenom? Yes, okay. This is a question, and maybe your opinion, Prof. Guterres, on this issue is important for me, because sometimes we receive patients who with an history of snake bite, but they didn't yet develop symptoms. So, if you have to accept to administer antivenom and to make a very, very early intervention, but with the risk to have some false positive cases, or we have to wait for symptoms to administer antivenom? Both of you, if you have a...
I can give my opinion, but okay. Well, actually, in the guidelines of Pan American Health Organization, it is very clear that in pit viper envenomings, antivenom should be given only after the symptoms and signs are developed, because usually local signs and symptoms, edema, pain, appear very rapidly after the bite. So in that case, the opinion of the guidelines is that you should wait until symptoms appear, even local symptoms.
Okay. Can I ask a second question?
Sorry. Your question is a question we have been discussed for many years about that. So we're not in the case of Atrox, we are in the case of botrops. Both of those snakes, they have thrombogenic potential. So we have a severity score. When the patient arrives, if there is no sign and symptom, as Professor Gutierrez said, you don't have to treat. We don't treat patients based on what they say. Jonathan said this morning, the diagnosis of snake bite in our case, St. Lucia or in Martinique, is based on the clinical aspects. If there is no clinics, no treatment.
Thank you very much. I just want to make a brief comment. I think it's very interesting that the three cases that you presented, there was no clotting disturbances. And this agrees very much with the cases in Botrops lanceolatus and with the experimental evidence that we have gathered. So very interesting. Thank you very much. Okay, our next speaker, we move now to Brazil. And is Dr. Juliana Sartorello Almeida from Centro de Informação e Assistência Toxicológica de Minas Gerais, CIATOX, and School of Medicine of the Federal University of Minas Gerais. And she will present the topic Snakebite in Brazil 2025, Data, Trends, and Perspectives. Welcome, Juliana.
Which one is yours? This. Sí, gracias. ¿No va? Es solo puntero. No. Ah, okay. Good afternoon. First of all, I would like to thank the opportunity to be here with a lot of personalities that I admire and who contribute to form my knowledge in venomous animals. So, I will speak, this is an index. First, I will speak about general epidemiology of venomous animals in Brazil, the epidemiology of snake bites envenomations, the more important incidence and lethality of these animals, the response time. I will address the importance of response time in snake bite management. I'll speak a bit about the genus Crotalus and its particularities, and some perspectives and research in the team. So, in Brazil, in this period of 10 years, between 2000 and 2022, we see that the bitten by venomous animals has increased a lot. almost 300,000 cases in 10 years. And you can see there that in southeast and northeast regions, these rates are getting increasing more than the other regions from Brazil. And we can associate this change with a lot of things: the climate changes, the changes related to the environment, the population growth, and the improving reporting. We had improved a lot the reporting in this time, but there is to a lack of education and awareness by people and professionals. So there are a lot of reasons for this increase in Brazil. This chart is very interesting because we show here which are the accidents caused by venomous animals in Brazil in 2023. The scorpions are the first ones with almost 200,000 cases. And the second ones, the snakes. And you can see here the lethality of the accidents with bees are the most one, almost 0.4% of the lethality associated by accidents with bees. The incidence of accidents with snakes in Brazil are about 16.8 in 100,000 inhabitants, and while the global incidence of snakebite accidents is estimating 69%, 69 cases per 100,000 inhabitants. So we have a minor incidence in Brazil. Here you can see the notification of envenomations caused in Brazil in 2023. And these snakes are responsible for about 9% of the accidents notified. You can see here too, the scorpions are almost 60%, but the snakes have an important part of the notifications. And you can see here that I think this is one of the most important charts I have shown to you. Here you can see the cases, the time for medical assistance for the patients, and the lethality rates. So you can see here that after 12 hours of the accident, the lethality rates start to increase, and it's very, very more important than when the bites are look for the care, the medical care, in the first 3 hours. Fortunately, you can see that the most of the cases are look for the medical assistance in the first 3 hours. This is a thesis, thesis from the boss of my service. It's not currently, but here we shows a bit this chart that I show you. He studied more than 800 cases in 10 years in our service by snake bites, and he showed that some factors were associated with the severity of the snakes, and one of the most important factors was the delay of more than 5 hours in assistance care for these patients. So we can see why this time is very important for the existence of this kind of accidents. Here's some spatial distribution of the snake bites accidents in Brazil. We have 4 genres of clinical importance in Brazil. So you can see the first ones, the accidents with the genus Botrops. You can see the major concentration is in North region. In second place, the crotalix accidents, crotaline accidents. You can see that in southeast and northeast, there are a lot that are concentrated accidents. The accidents with elapid accidents, you can see in all the country, but with minor rates. And the accidents with lachesis that are concentrated also in north region. And here, the Botrops is the king of the snakes in Brazil. They are responsible for more than 80% of the accidents. My colleagues from my country will speak a lot about the Botrops, so I choose to speak about Crotalus, because in our region, the prevalence of Crotalus is very big. It's almost the same of Botrops. So here I am showing you just a chart with the snake bite incidence by Botrops in the country. So you can see here too, in north region, they are more prevalent than the other regions of Brazil. About the Crotalus envenomations, you can see here that they are concentrated in northeast and southeast of Brazil. You can see here about 40% of the accidents occur in northeast and 35% in southeast. Here, when you see the incidence by states, you can see this more blue state is my state, Minas Gerais. And we have about 24% of the total of the accidents with Crotalus durissus, the genus, the species, we have more there. And you can see that is a very significant rates. The Crotalus durissus is formed by 11 subspecies. In Brazil, we have 6. And the accidents with the Crotalus durissus are about 8% in Brazil. Why do we have a lot of Crotalus in our region, in Minas Gerais? Because they inhabit regions of dry and rocky climates, rocky regions, environment. So the region of Minas Gerais has a lot of cerrado. You can see there the yellow part of my state. Almost all of the state has the best place for this kind of snakes. So they like a lot to live there. And what are the characteristics of the Crotalus? I like to say it's a rattlesnake, so it has a rating tail. The males can reach up 1.5 meters. The coloration is brown with dark vertical diamonds. I like to say to my academic stages, the stagiaries at our service, that they look like pure light diamonds. There are a lot of diamonds in the snake. I don't know how to say the dorso of the snake. The back. Thank you. So a lot of diamonds in the back of the snake. And this is the first, the principal characteristics of this genus. So, the venom properties. We have 4 groups of toxins: the crotoxin, the crotamine, the convulsin, and gyrotoxin. The crotoxin is responsible for the neurotoxic symptoms. The crotoxin and crotamine are responsible for the myotoxic symptoms that are the most important symptoms we see in our patients. And now I will show you a lot of photos from my service to show how is the evolution of these accidents there. One characteristic that is very different from the crotalin genus predominant in Central and North America is that we have no edema, no pain at the place of the bite. So the crotalin, the C. atrox and the C. sinus has a lot of symptoms, local symptoms, and our Crotalix accidents has no symptoms, local symptoms. So it helps us to identify the accidents, because in my regions, 50% are botrop accidents and 50% are Crotalix accidents. So when the patient comes with a big snake, would say that it's a big snake, and has no local symptoms, we suppose that it should be an crotalic accident. The clinical manifestation, more important one, is the neurotoxicity. The patient initially has deep diplopia, blurred vision, and pitosis, dysphagia, nausea, vomiting, and can evolve with respiratory distress and respiratory failure. But this is a rare symptom. You can see here, we have some problems with these patients because most of them arrive to us after drink. So they have this drunk face, and we don't know if they are drunk or if are bitten by a snake. And they have this smell of a drink because they normally they are working at a farm and drinking and come with the bite and this face, and we don't know, with no snake, this face, and we don't know if it's the snake or the alcohol. Another clinical manifestation, important clinical manifestation, is the myotoxicity. These are the urine of our patients. The creatinophosphokinase from these patients are rise 100,000. It's very high indices, and this is the first cause of mortalities in these patients are the renal failure associated with the rhabdomyolysis. The bleeding are less common than in botropic accidents, but we see too. This is a gingival bleeding here. We see hematuria also and ecchymosis in these patients. And other clinical manifestations are associated with renal failure, oliguria, anuria, uremic signs. The patients can have also local secondary infections and thrombocytopenia. Here is just it's a table with the systemic manifestations of our patients from Minas Gerais in 10 years. You can see that neuroparalytic signs are responsible for more than 65% of the signs of these patients. Hemorrhagics, myolytics, and renal are less common than than neurotoxic manifestations in our patients. This is just a curiosity. We have, as I say to you, it's rare to have a respiratory failure with this kind of accident. In 10 years in my service, we had 2 patients, and this was one of them. He stayed 4 hours after the bite. He had completely diaphragmatic paralysis and had this respiratory failure. And in Minas Gerais, in 10 years, we had 43 cases. It's the second region, state in Brazil in respiratory failures. In this case, the first one is Maranhão, with about 35%. Here is just the severity classification. This table is the newest one. This new protocol of OFIDism in Brazil has been published in October from this year. So you can see here the severity classification of our accident. I was also talking with my colleague from Brazil FAM today that for us in my clinical practice, the neuroparalytic changes be evident in moderate and severe case is also a problem because it's difficult to differ the classification. Also because to us, the neuroparalytic symptoms are the most prevalent, and the myotoxic and renal impairment generally occur within 5 hours. 5 hours, 6 hours. So most of the patients arrive to us just with neuroparalytic symptoms. So we have to more and more improve the ways to characterize this kind of accidents. I'm almost finishing. This is a chart with the outcome of the patients by region in Brazil. You can see that in almost all the states we have more than 80% of cure of this case. In Minas Gerais we have 90% of cure, and 9% of not knowing, not identified the outcome. And to finish, I want to show you some ongoing projects we have. We now are doing a clinical trial, because in Brazil, in most of the regions, the antivenom is doing diluted ones, vials, and we do in undiluted one. For 30 years we are doing without diluting the antivenom, and now we are doing an clinical trial to compare the two ways to see how will be the adverse effects. Another clinical research we are starting is to assess the lesions of Bottrop with the point of care ultrasound. That's why I asked the colleague first. And we are trying to characterize the lesions of these patients with the ultrasound. The last one, we are doing an extension project with the University of Minas Gerais to identify the mortality by venomous animals there and train the professionals to improve these rates. And to finish, our perspectives are to promote partnerships with universities, hospitals, and other institutions, and qualify more to research with these groups to improve our knowledge about venomous animals, and train any day more the healthcare professionals to improve these rates of mortality and morbidity of these patients. So that's what I have to say to you. Thank you.
Thank you very much, Juliana. Stay here for the questions. Any question for Juliana or comment? Yes, Remy.
Thank you. Thank you for this nice talk. I'm not a specialist of Crotalin, but my question, for instance, when you spoke about acute respiratory failure. So if I understand well, there could be two causes of it. First of all, a neurological attent of the phrenic nerve, but also myopathy because of the necrosis of the cells. So how do you make the distinguish between the two causes?
Until now, our knowledge shows that the first cause of respiratory failure in these patients is because of the diaphragm paralysis. So the patient starts with the petosis, dysphagia, and at the finish paralyze the diaphragm, and the respiratory failure come from this consequence.
Yes, Jacqueline.
Thank you for your presentation, Juliana. It's a very good for different symptoms that the north region, the Botrops, for example. And my question is a practical clinical. And what is a challenge for the identify or treatment or classify this accident with Crotalus?
Yes, as I say, we have 50% Crotalus and 50% Botrops. When the patient bring the snake, it's easy. But when the patient don't bring the snake, we have to wait. So you have to wait the laboratory alterations and the symptoms the appearance of the symptoms. The biggest challenge in this case is when it's how can I say, a small snake, an infant snake, a child snake, because the crotalus and the botrops has no signs, the local signs. So we have to see the symptoms and the lab until we have strongest suspicion to do the genus-specific antivenom.
Yes, Davor.
Thank you for your nice presentation. Always from Brazil. So I have a little question for you. It's a clinical one. So we know in Elapides, we don't have, and we know the differences clinically between someone who get by Elapidae or Viperidae family. It's easier to us as a clinician to know that in the Viperidae it's very rare to have neurological symptom. You said you have to wait, but my problem is that the waiting time. I don't know how many times you're going to wait when we have some symptomatology, some symptoms, clear symptoms between Elapidae and Viperidae. And the Elapidae also, you have a clear sign in the urine, the myotoxicity. You can just do a little test and the urine that will give you something. And the CPK, all those things, you have a lot of bunch of things. I think for a student, medical student, emergency one or student in intensive care, we cannot give that message. It's a very hard message to tell to our student, because we have 50% of Viperidae, 50% of Elapidae. We have to wait because the patient doesn't see the snake. So it's not the message we give sometimes to them. I think it's easier for us as a clinician to know somebody will get bite by Elapidae, Crotalus, and versus non-Crotalus.
It's a good question. So we have two things that helps to make this difference. First of all, the Elapide accidents in our region are about 1 or 0.5% of the accidents. So the incidence is very, very rare. Very, very less than the crotalic ones. And the second one is that Elapide accidents has no lab alterations. So when the patient comes with coagulation alterations, rhabdomyolysis, and all these other common alterations, we can suspect in crotalic. Another difference is that because the elapidic accidents by us, when the patient evolve with diaphragmatic paralysis, it's very, very fast. The first half an hour, 2 hours. So this is a difference between the crotalic. And we have this kind of lucky to have this accident like a rare one.
I have a question for you. You know, some Crotalus terrificus venoms are crotamine positive, some are crotamine negative. Yeah. Do you see sometimes manifestations of the crotamine action like myochemia or fasciculations in some patients? Some that may suggest that these venoms are crotamine positive? I mean, do you see clinical manifestation of crotamine action?
Yes, sometimes, and sometimes we have this two kinds of patients. We have patients with these neuroparalytic signs and these fasciculations, these signs, and with less coagulation alterations. And when we see patients with a lot of coagulation alterations, normally they have less neurotoxic, neuroparalytic symptoms. So it's just an observation. So we can see some kind of difference in these patients.
Thank you very much, Juliana. Another question, sorry.
Just one small question, but I don't understand. Is all the neurological effect you describe is curar related, curar like naja naja, or something else?
It's like naja, you said? The neuroparalytics. The Elapida genus is a bit different because I don't know a lot the naja envenomations. So the neuroparalytics symptoms in naja are rapidly and more severe, I think. In Crotalus, the most patients with 12, 15 hours have just pitosis. So it's less severe.
Thank you.
Thank you.
Okay, our next presentation is by Dr. Jacqueline de Almeida Gonçalves Sachet from Universidade do Estado do Amazonas in Brazil, and she will present the work on local complications of Bothrops envenomation and challenges for clinical management. Welcome, Jacqueline. Your presentation.
Yes,
But I think tienes que ponerla aquí. ¿O será que está?
coloquei lá com eles. Você tem que pôr aqui ou pego?
Coloca aquí, tienes el- Es que él está pasando por YouTube.
Ah, sim, não sabia. Desculpa. Sim, minuto. Ai. Sim. Okay, good afternoon. I wait. Everyone is woke up. And I am very grateful for the invitation, Brazil, for this section. It's a very good opportunity for the approach of the many researchers. Thank you, Dabo. Thank you, Dr. Gutierrez, for invitation, for remember of the us again. And today I will talk about local complication and envenomation and the challenges for the clinical treatment. My colleague, my colleague talked about distribution of the snakes in Brazil, and today I will speak especially about the Bothrops. The Bothrops is a snake in north of Amazon, north of Brazil, specialized in Amazon, and I work in Tropical Medicine Foundation in Manaus. And the summary about this presentation is a botrops envenomation, accident classification by botrops, local complication, and the local treatment. I don't know, no. Is a different. Oh, but no, not appears in. Strange.
We need some help here.
I will close, open again.
Okay. There you go.
Yes.
Aquí.
I think yes. Okay. Yes. Okay. Okay. And the botrops in Brazil is responsible for 90% of the total of the snake venoms. And the popular name is in Brazil is a jararaca. And it's a crepuscular habit because of this explain the person, the profile of the person that suffers snake bite is in rural area because of go to work in very early and come back in the end of the afternoon is the time of the snake go away for the prey something or the move it in the forest. And is a snake very calm, only attack when they felt scared and when it's a treatment. Then about the first challenge for the management, the clinical practice is about this side is envenomation or not? In Brazil, the hospital sometimes use tools that help very well for the clinical practice. I brought for you my camera, my equipment is a thermograph. I don't represent this brand, please. It's only for use for the practical clinical. It's very good for the side, for complement the clinical observation, if envenomation or not, because this thermographic capture the change, the temperature for more or less, depending of the case. And I brought two cases in this slide. The first case is a dry bite. Dry bite when the patient brought the snake, for example, brought the jararaca for us, but don't have any symptoms. And the professional of health, there is a doubt. Yes or not envenomation? I will wait how many hours I will wait for appears the symptoms. That use the thermograph and decide, because past the time, for example, 6 hours after the bite, and they take a lab exams, and the evaluation, the physician is not appear symptoms, for example, and they use for decide and finish the diagnosis. And the first case is a dry bite, brought the jararaca snake, for example. And in this image, it's possible you see is the same temperature, the both legs. And if together, this image, the professional decide is no envenomation, don't use the antivenom. In the second image, the physician in the hand no have edema. Is a normal skin, for example, is a normal for the edema when you compare the both hand, but is a doubt. And after the thermographic, you can see in the white area is an inflammation area, appears in the mild case and they classify with envenomation and they give you antivenom. Because of this tool is a good strategy for help the professional when the doubt, the symptoms or the exams appears. And then sometimes used to, when the patient didn't bring the snake, for example, and is a no venom snake. Then this image help for the finish the diagnosis too. And in the envenomation case is a good for this. Well, in botrops envenomation in Brazil, the protocol recommend the 3 classification cases, the mild, moderate, and severe. And this classification depends on the local symptoms and the systematic symptoms. And for the local symptoms, specify about the edema, the pain, and they compare one leg, the other leg, or one hand, the other hand, for example. When the patient is a classified mild case, use 3 vials, moderate cases 6 vials, and the severe case 12 vials. All the antivenom in Brazil is produced in Butantan, is the same for all Brazil, for all the botrops envenomation is the same vials, using the same formulation. Then, inside the vials, without botrops atrox, but in studies in Manaus, for example, the botrops atrox, the venoms worked no problem. It worked and they reduce disturbed coagulation and they reduce the local symptoms too. Then is an example about the evolution of the edema and the evolution of the inflammatory local symptoms. In the letter A, you can see a mild case. For example, the bite is in the foot, and the edema until the almost the knee, for example, is a mild, classified in the local symptoms like a mild case, use 3 vials. And the letter B, for example, is more than foot, is almost the knee, the middle of the leg, for example, classified the moderate case, 6 vials. And the letter C, the all leg develop edema. The all leg represents the severe case, is a severe case, use the 12 vials. Then I use again in hospital, use the thermography for evolution, for follow this edema, follow this inflammation with I need more vials, for example, after 24 hours, the first admission of the patient, or not. Is possible use more or decide the clinician symptoms more than thermography, for example, more vials. In this case, when you see with only eyes this case, the edema is a little bit more in the right leg, for example, the left leg. In the right leg, it's okay. But when I use the thermography for the evolution of the inflammatory process, identify that half leg is inflammatory yet. Maybe is a good for decision for keeping the patient in observation or apply more antivenom, depending of the symptoms and the symptoms and signs, and when you compare for admission case. Then use it too for the evolution in local complication. In the first line is a normal case. The patient didn't develop any local complication. In the day 0 is admission until the day 7, when the patient come back to the hospital. The evolution, the legs is normalizing. You can see in the line, they're normalizing with thermography image. And in the second line is a different, because it happened the secondary infection, for example. The patient no normalizing 7 days in the middle of the line, and when the patient come back to 18 days after the snake bite, you can see that the leg, there is a difference of the temperature yet. Is that good for the evolution is good or not? You wait for the temperature go back or not after the antibiotic. Then, for a good standard for evaluate this patient, the good way, the group use standard record and use the same information for all the patients. Because sometimes if you use the record with a blank page, the professional put one time some data, or the time, or the data, and no correspondence when you come back to the record for build a base of data. For the similar information is compromised. Then this information is about bleeding of the local of the bite, edema, for example. For measure edema, use the centimeter around the leg, for example. And they collect the information about the pain, use the scale the 0 and 10, and the patient choose the number day by day. With this ecchymosis, blister, or the type in the skin too is evaluated. Then is a curiosity case that in group observed in FMT, that there is a collection of the snake, and when you take the snake that patient brought in the hospital and compare with symptoms, sinus symptoms, the research observed that the juvenile jararaca, juvenile botrops, is developing in the patient, the venom developing the patient more coagulation disturbs. When there's an adult snake developing the patient more local manifestation, then the group expected when the patient arrived in the hospital, when there's an adult snake, more manifestation, local manifestation, than coagulation disturb and change. Is a practical evidence for use, and pay attention for the more manifestation you can find in this patient. This study is about the return of the coagulation disturb in the patient when I use the antivenom by Butantan that without Botrops atrox, and the curve is possible to see that the reversion of the coagulation disturb. Then is other complication that happened with the patient is about the blisters. The blisters happen when the patient uses mainly tourniquets, for example, when this is a lot, the snake injected a lot of volume of the venom in the patient, and happened, they formed the blister in the patient. This blister is a challenge, and because what is inside the blister? Then the group resolved discover inside the blister what to do in the blister. I can aspirate or not, I break the blister or not. And when aspirate the blister and analyze the liquid of the blister, we found a venom and the antivenom inside the liquid of the blister. But the venom isn't connected with antivenom. Then the venom is active venom. Because of this, is a recommendation to break the blister, because this blister keeping the venom activity and the proteolytic action continues under the blister and form the ulcer in the hours and days, for example. Then is another study about the secondary infection. That is my doctoral degree project. And I use clavulin, amoxicillin with clavulanate, is used for prevent infection in the patient. And in the end of the study, this antibiotic didn't prevent 50%, that is outcome, didn't prevent the secondary infection. Because of this, not recommendation use the antibiotic for prevent secondary infection, only for treatment. And about the treatment, the hospital use more than clindamycin, and is a profile the antibiotic that use in the hospital, use more clindamycin, and they resolve the most of the case. And some case need a change or add other antibiotic, but clindamycin alone it's okay for the Botrops atrox in Manaus, for resolve the secondary infection. Then other problem and complication is about the compartmental syndrome. Compartmental syndrome is a challenge for us. And one research about this patient, and they use 111 patients for the control group without compartmental syndrome, and the 37 patients, the group case with compartmental syndrome, and the patient that living in rural area is a risk for develop this complication, and they spend more time for arriving in the hospital for receiving antivenom. The patient that is affected, the lower limbs, for example, is more complicated because the anatomic muscles is a problem, and the fascia constrict, they expand the edema, and because this is a risk for pressure the vein and develop compartmental syndrome. And the blister and the secondary infection is a risk too, because it improves the inflammatory symptoms in the local. Then other discovered with this patient is about creatinokinase. When the patient, there is a level more high, the creatinokinase is more risk for the develop compartmental syndrome, especially in the second day. The second day, the more high this creatinokinases is a risk for develop the problem. Then is patients in the evaluation. This study about the compartmental syndrome that develop. Many cases can develop, and after the patient discharge is a problem too, because the disability is occurred permanently. Then now the group will work with ultrasound point of care for discovery previously some complication, like a compartmental syndrome or secondary infection or necrosis, for example, is a other type the discovery that use for point of care ultrasound. And the unique study that evaluated the series of the cases is occurred in Taiwan, that evaluate 70 patients, and the ultrasound is useful for discover some reflux of the artery, for example, and help identify the compartmental syndrome, and maybe this is a good evidence for use in protocol in Manaus. Then in the local in the local of the bite, why is possible use in the local for treatment of this patient? And a group develop a protocol that use photobiomodulation, and this photobiomodulation used in 3 days, consecutive 3 days, one time, once a day, and reduce 50% of the myonecrosis this patient. And the photobiomodulation is this, in this image, is a equipment very small. It's very easy for apply in the patient, and it reduced creatinokinases in 15%, pain in 50%, edema in 50% too. Is a good tools for use, treatment for use for reduce the inflammatory symptoms this patient. And unfortunately, the other clinical trial that the group developed is about the cold and the hot therapy, because many professionals prescribe the hot or the cold therapy, but is good or not, resolve or not, help or not the patient. And the group discovered that when I use only cold therapy is good for reduce the pain only, because the edema, myonecrosis, temperature, nothing is resolved, only for reduce the pain. Because of this, the many procedures for the patient, use the team of the health for reducing only the pain. When you use this procedure, the group resolve, don't recommendation the cold or the hot therapy. But if you unique alternative in remote area is good for reduce pain. Then there is many kind of the cases with dirty skin, for example, appears in the cervix, is difficult for evaluation the patient. The bite, the most of the bite is a closed wound, is a difficult for the identify what happened under the skin, for example. And the ecchymosis happen too, but sometimes both 2 or 3 symptoms, complications happened with this patient, like a blister, a secondary infection together, blister, necrosis, secondary infection together, and the blister, ulcer, and muscles loss, for example, then happened with this patient. And the blister necrosis, muscles damage in indigenous areas, for example, is a problem because it's a complex access and procedure of the health. And in adults, in child, is happened disability after discharge. Is a next challenge of the group for the follow this patient and try help this patient for some rehabilitation, for example, or resolve something that is possible. Then is a child that is a male, 10 years old, and they have the secondary infection in the lost muscles, this patient, and there is a loss of the muscles is a disability, is a permanent problem for this child. And for finish, this is a protocol of the group developed, and this protocol is in English for this publication, is about the practical clinical, the captures about the practical clinicals is very access language for the professional health, and for the inside the hospital, outside the hospital, same recommendation. And the base of this is a recommendation of the health minister of the Brazil. Then is a research group. In Manaus, the group made toxinology, researches, biology researches, clinical researches, and there is a biorepository that more than 250 patients, they continues with the data and the sample keeping for the studies. Thank you for paying attention.
Thank you very much, Jacqueline. Time for a couple of questions. Yes, Atem. Okay. Go ahead.
Yeah, thank you. Thank you for your nice presentation. It's very interesting. I wanted to ask you, do you see, or how frequent do you see fibrosis in the skin of these patients, and if you're investigating on possible methods to approach and to improve this skin regeneration?
Is fibrosis after discharge? Oh, yes. Is a problem for the follow this patient, because this patient after discharge, this patient changed the phone and moved for the other place. And for the evaluation again, this patient is very difficult. But when find the patient, and this fibrosis only for the sensitivity or the loss, sensibility, for example, this evaluation. The group no develop for the biopsies, for the investigations, is other cells, for example, only for observation what happened, this fibrosis or the mark of the skin.
I just wanted to ask how frequent is in the patients you see?
Yes, but the frequency...
You don't have this information because they don't come back?
Yes, it's very difficult because it's complicated see again the patient.
Okay.
Because it's living in rural area, is very far for the go run at this patient, for example.
Okay, so there's no date. Thank you.
Thank you very much, Jacqueline, for this excellent presentation. This morning we said that clinical manifestation, and I think that it's better now to say acute clinical manifestation because there is maybe clinical, chronic or delayed clinical manifestation which may appear in the course of the disease. So acute clinical manifestation are related both to the venom itself but also to the inflammatory reaction. And the acute local manifestation, I think that they are the result of the local venom action, and they are contributors for the general reaction, general inflammatory reaction, and that the systemic inflammatory reaction is triggered at the seat of the bite, and then the worse are the local symptoms, the worse is the envenoming. And so that acute local symptoms are the reflect not only of the local manifestation, but they can also reflect the general and systemic response of the body to the envenoming. What do you think about it?
And there is other line of the research in Manaus that use the blood for identify all the cells, the inflammatory cells. For example, cytokines, interferon, is all the cells. And about the clinician is a mix for the inflammatory symptoms and the venom manifestation local. Is a mix when is a clinician in the practice in the hospital. I think it's impossible for difference between the both because it's a mix for the practice evidence. But in this research, and they use, for example, the biomarkers and the local manifestation and the check is the low and the high. There is other research about this. I can discuss with you or send you for the more detail about this. But there is biomarker that used for identify inflammatory manifestation, the venom damage in the muscles.
Thank you for the excellent lecture. In my region, we see a considerable number of patients bitten by non-venomous snakes who do a local reaction, important local reaction, like cobra cipó, Phyllodes offensis. Have you ever compared this strategy, the thermal strategy, between botrops and non-venomous snake bites with a big local reaction?
Yes, but this causes confusion for the diagnosis because you confuse, for example, the no venoms with a mild case botrops venoms. Because the same symptoms, the mild edema, for example, the mild pain is possible have a confuse, and the thermography when they use is the same for both.
So it has no place to differ the two ones.
Yes. For clinicians, the same.
Okay.
When the patient take a picture for the snake, all brought the snake is good. But when the patient identify the snake, usually the professional give an antivenom for the patient.
Thank you.
Thank you too. Isso. Eu acho que o seu não está aqui também, não. Eu estava falando assim.
Colocaste.
Aqui. Mas está. Ah, tá. Esse é isso. Esse pé. Esse.
Our next speaker is Dr. Wei Wen Fan from Instituto Butantan in Sao Paulo, Brazil. And we will present the work Decentralization of Antivenom Treatment in Community Health Centers in the Brazilian Amazonia. Welcome, Wei.
Good afternoon, and first of all, thank you very much, Chema and Dr. Dabor, for the opportunity to return to Costa Rica to see old and new friends and being with all of you. Well, this is the first time I'm going to speak in English about this project. I don't know how I'm going to do it, but anyway, talking about Brazilian Amazonia, I shall say how to move. Okay, no. First. No. What's happening? Okay, here. It's not the same. I have to look at here. Just to remind a little bit about the area which we are going to talk about. Brazilian Amazonia occupies 60% of the Brazilian territory, but the population is very low, representing only 13%. But in Brazil, everything is big. So this 13% represents more than 30 million people living in this area. And in the Brazilian Amazonia, or in Brazil, and in fact, more than 1.7 million indigenous peoples are self-registered as indigenous, which represent a very low percentage of the total population. However, in Amazonas, or in Amazonia, half of these indigenous are located in different states, representing 67,000 population, distributed in more than 300 ethnical groups, and sometimes each one living with their own culture and language. And just to let you know how the health policy in Brazil works in terms of snakebite surveillance and antivenom distribution. We have two pillars in this program, or in this policy. One is based in providing antivenom for every patient that needs it, free of charge. And the second pillar is the information system, in the way that every snakebite envenoming has to be notified to the health system, which is decentralized from the Ministry of Health to 27 states and more than 5,000 municipalities. However, not all of them receive antivenom. In fact, less of 50%, around 36% of municipalities have hospitals with antivenom available for the treatment. If you see the map, the distribution of snake bites, or the number of cases, we can have a wrong impression that most of cases occur in the coast of Brazil. But the size of these bullets shows that the main incidents, or the higher incidents, are in Amazonia. More than 4 times when compared in the extra Amazonia region in Brazil. But we guess that we still have a lot of underreporting cases, because distances between one municipality to the other where patient can receive antivenom are very large, and in some seasons, in the dry season especially, the transport by boats can be very difficult, and patient cannot reach these hospitals in time, or sometimes they even don't go to the cities for the treatment. And is why we see the case fatality rate, for instance, in Amazonia, is nearly the same in the extra Amazonia. We think that some patients die without even being reported, without being treated. It's difficult to see. This is the map of distribution of antivenom in Brazil. And here we see that we have much more hospitals, much more municipalities with antivenom in extra Amazonia than in the Amazonian region itself, although the incidence is much higher in the Amazonia. And this represents a great inequity in the access of antivenom in Brazil. So, because of it, a project named SAVING, and the message is the antivenom, snakebite antivenom immunoglobulin need to guarantee to everyone that need it. So this project aimed to develop a validate a minimum requirement checklist for snakebite treatment in indigenous health care units. Also to train the health staff working in indigenous territories, and to decentralize the distribution of snakebite antivenoms to 14 indigenous healthcare units in 7 indigenous territories by an uncontrolled quasi-experimental design study. In fact, it will be a real-life data collected from this project. And the symbol of this project, the SAVING project, is the immunoglobulin, as you can see, with 2 colors, because we have in front of Manaus just the meeting of waters, which is a very big, beautiful phenomenon that some of you can have the opportunity to see if you attend the IST meeting next year in Manaus. So save the date and prepare yourselves to go there. So the coordination of this project is, or I would say the mentor of this project is Professor Welton Monteiro from the Foundation of Tropical Medicine in Manaus, capital of Amazonas State. There is a group of research where Dr. Jaqueline is part of it, other colleagues, Felipe Murta, Vinicius Machado. I myself am very proud of being part of this group, and João Vissossi from Duke University. And this foundation has a referral hospital for the treatment of patients with tropical disease, including accidents by venomous animals. The hospital receives medical residents from all of the country to be trained just in tropical medicine. And there is also several centers of research in epidemiology, in different tropical disease, and a group dedicated to graduate studies. So before the implementation of the project itself, a lot of work has been done before in the pre-implementation phase. And it started in 2019 with some discussion with indigenous leaders that demand, in fact, this demand is older than this time. But in 2019, we'll have the opportunity to have a huge discussion between the indigenous health system representatives and the representatives of the Ministry of Health that deals with surveillance and antivenom distribution. And it was decided to form a group, a technical group, to study how to do this decentralization process, involving different actors from Ministry of Health, from the Foundation of Tropical Medicine, from the Foundation of Surveillance in Health of Amazon State, from a special indigenous health district, and with the participation of Instituto Butantan, because we were at this moment the only laboratory that provided antivenom for the country. Another step in this pre-implementation phase was to develop and validate a minimum requirement checklist for snakebite treatment in these indigenous healthcare centers, and to develop and validate a cultural guideline. So it took a long time for us to establish the requirements for this checklist and to identify the potential indigenous healthcare centers that would be able to treat the cases according to some parameters that were considered obligatory to these healthcare centers. First, snakebite envenoming should be imported in a given indigenous area. This area should have availability of electric power. Transport of patients should be available also, and this area should have a physician. After identifying these different indigenous health centers, another work was to develop, validate, and apply a checklist with 80 essential lists of this health center, on each this health center should have, including human resources, so not only physicians, but nurses, nurse assistants, and other professionals. The minimal equipment, supplies, and medicines. And all of this work was published in this paper in Toxicon, I don't know, 2 or 3 years ago. The guidelines that was modified from the guidelines from the Ministry of Health also in the way, was developed in the way that it could be culturally relevant for indigenous health professionals. And the implementation starts in 2022, first with inspection visits and accreditation of these indigenous health centers, training professionals, and distributing the vials to these healthcare centers. And this is a very amazing case because it was the first patient that received antivenom in this saving project. It was in November 2022, and it occurred in an 8-year girl, indigenous girl, and she was beaten 48 hours before the professional team was called by the father of the child because she has a non-stop bleeding. She was in a very bad condition. She could eat. She couldn't eat. She couldn't stand up, and the father was resistant to take the girl to the health unit. They wanted the team to go to the village and treat the patient, and it was done. And as you can see, the testimony of the nurse, the effect of the rapid effect, the recovery of the girl, stopping the bleeding, she started communicating with the people, and after this improvement, father of the patient, the girl, agreed to transfer to the health unit to complete the assessment, and this girl, I think she stayed in the unit for 2 or 3 days and then was discharged without any complication. And the impression is unfortunately you cannot hear the audio of the nurse saying how impressed were the assistant and how they are satisfied to see the result of the procedure. So in terms of the assessment of this project, we have two types of analysis. One is quantitative, the other is qualitative. I'm not going to discuss the qualitative analysis because it's quite complicated for me. I'll just present some data of the efficaciness when we compare data pre and post intervention based on information that was reported in the official information system. So we divide the groups of records in the intervention group composed of patients receiving antivenom at indigenous base pole, as we call in Portuguese, Polo Base Health Center. Since the beginning till the middle of the year, we had 125 cases reported, and another group was represented by patients that received antivenom at the Heffer Hospital, which is located in the urban area of the municipality. The same number of records were analyzed, and data were paired according to the resident site. That means patients were beaten or lived in the same area. And some outcomes were analyzed as proportional patients receiving antivenom in adequate time. We consider less than 6 hours. The severity rate, when we have these 3 grades, the rates of local and systemic manifestation, and the case fatality rate. So these are the characteristics of the patients. They were similar in terms of gender, age groups, type of envenoming. Most were botrops envenoming. Anatomical site of bite also the same. In terms of the variables that assess the effectiveness of the project, of the decentralization of antivenoms, we see that we have much more patients arriving in adequate time, in less than 6 hours. It's not working here? Yes, it is. We have much less severe cases or much more mild cases in the intervention group. We don't see a difference in local complication, probably because of the sample size. The manifestation, the systemic manifestation was not very different in terms of bleeding. In terms of acute renal kidney injury, we had more in the control group, maybe because we don't have, we could not recover all data from the patient in the intervention group. And the outcome, most of them were discharged without complication, but we had one disease in the intervention group. It was a patient that arrived in a severe, very severe condition. At the moment, it was a woman. At the moment, she arrived at the indigenous healthcare unit. And unfortunately, the transfer to hospital was not able to save the life of this patient. But anyway, we have also some disease in the control group. Another interesting data in comparison between these two groups shows that we still have in Brazil a tendency of overdosage of antivenom. Even if we had trained indigenous professionals, even if they have the guidelines available, they still give more than necessary. And it was very, I think it was a very interesting result, because it means that we have to do more in terms of training. And anyway, I think we still have a good percentage of patients that receive antivenom as recommended, even in these two groups. So I said that I wouldn't talk about the qualitative data, but believe on me, they have been analyzed. There are very good responses, positive and negative, in terms of 8 different categories in a scale of qualitative data. But I want to highlight one, which I think it touched me a lot, which is the category of ethicality. When health professionals express there is a great sense of justice in the saving project. And this is a speech from one of him, when he says that indigenous people must have fair and equitable access to antivenom. And this project was followed by the Ministry of Health. And in parallel, they realized that they should decentralize the distribution of antivenom. And I didn't talk about this when the slide was shown in the first time. But in Amazonia, we have 745 municipalities, 543 municipalities with antivenom. And before the implementation of this project, there were 597 healthcare units with antivenom. After this saving, Ministry of Health increased in more than 50 points or 50 health care centers, all of them indigenous healthcare centers that are now provided with antivenoms. And in Extra Amazonia, it didn't change. This is the work of a huge group represented by some of them that are here. I will say that I'm very proud to be part of it, to see the results and the reverse of a situation that we have been facing for a long time. It was the inaccessibility of antivenom for in remote areas to vulnerable people. So this is what I want to present. Any complaints, please send an email to Walton. Any compliment, send me. Okay, thank you.
Thank you very much, for your presentation. We have time for one question. There you go.
Thank you very much. I really liked your presentation, especially when you spoke about the child receiving the antivenom and the changes. I just wanted to ask you though, I know Brazil is very big, you have rural areas, etc. I'm curious about how you get information across so that you can have data and be able to make analysis and make decisions, because all of this, including the importance of having a proper health information system, will assist with the referral, because I think one of the previous speakers spoke about loss to follow up and sometimes you don't get them. So I could quite imagine the persons in the Amazonia, how difficult it is. So I just want to know, how do you garner information to make decisions? Thanks.
Brazil has a program for snakebite control and surveillance since 1986. So almost 40 years of the program in which, as I said, this program was based on information. And now we have an electronic system in which we can just type in the computer the data of the patient, and this goes from the hospital to the municipality to the state level until reaching the Ministry of Health. But it's not enough, we know, but at least we have a good picture of what happens in Brazil in terms of snake bites. As Dr. Juliana showed, the epidemiology of snake bites in Brazil, although we know that we have still underreporting case, give us a photography of how to manage, how to establish the policies. And because of this big distance, especially in Amazon, we were very concerned, always very concerned about the accessibility. And we have very strong social movements, especially indigenous groups that require antivenom. This is an amazing thing, because we thought that perhaps they would prefer traditional medicine, they will have some resistance in receiving antivenom, but it's not the truth. They have resistance in going to the hospital, to the health center, where they cannot find their culture respected. So this product also brings this element of culturally relevant aspect that have to be connected with antivenom treatment. It's how we succeeded in getting these indigenous health centers in our requirements, including fulfilling the form of notification, which is not the routine for these groups, but they agreed to do it because they understood the importance of having antivenom in the center. And it's not an easy task, but we believe that we can manage in this way. Okay.
Thank you very much. And we come to our last presentation of today by Dr. Frédéric Lapostole from the Université Paris 13 in Paris, France. And Dr. Lapostole will present a topic on antidotes to be or not to be. Did you? Yes,
The best is I don't touch anything.
Okay. You can. tell me.
Probably this one.
Well,
Yes.
I will do that because it works better.
That is the question.
Let me see if it works
Yes.
because it's in the presentation
Yeah.
there. I'm not sure if it works. I don't know why it's not working. It's because it's here. Let me see if it works better. Yes, it's working.
It works. So, it's my pleasure to share with you our experience and reflection on the use of antidotes. When we talk about intoxication, we immediately ask the question of antidote. Do we have antidote or not? And I would like to illustrate the reflection about antidote availability with 4 intoxications. First one. Few weeks ago, I was in Laos for training for emergency physician in a deprived country where emergency medicine is not yet an academic specialty. Recently, they had to manage severe methanol intoxication. For those who are not comfortable with methanol, it can come from bad technique of alcohol production, but usually it comes from addition of methanol in ethanol because it's cheaper. Methanol is toxic not because of methanol by itself, but because of its metabolism, producing acid and then responsible for metabolic acidosis, and with severe ocular toxicity with blindness. You can see here from methanol to formic acid and systemic toxicity. And we've got severe intoxication with death, but there is an antidote. Very efficient antidote, known since a few decades, but in this case, it was not used. And this is a major issue because such kind of intoxication is very frequent worldwide. And you can see in the last case, more than 100% died because of methanol despite antidotes. I discussed with my colleagues and they say that maybe it's not easy to diagnose methanol poisoning. But in the case of a patient, a comatose patient with acidosis, you've got to think about this hypothesis. Moreover, in case of more than one victim, and of course, in case of ocular complication. Then I tried to challenge ChatGPT. You know ChatGPT? I just asked this question yesterday evening. 5 comatose patients with metabolic acidosis. The answer is immediately only one, methanol poisoning. They said, yes, but we don't have analysis allowing to have methanol dosage in blood samples. It's not available everywhere and it can be expensive. Yes, but you can use indirect strategy to confirm methanol poisoning using anion gap. In the case of increased anion gap, in emergency department, usually it's due to lactic acidosis or diabetes complications. Both are easy to rule out. So, if it's not metabolic acidosis explained by diabetes complication or lactic acidosis, you've got the diagnostic. It's due to exogenous acid, and in most of the cases, it's methanol. So the question is, antidote. We don't have the antidote. But it doesn't matter. You see that the... Yes. Fomepizole is expected to block alcohol dehydrogenase. And then, if you block alcohol dehydrogenase, there is no production of acid, there is no methanol metabolite toxicity. If you don't have fomepizole, you can use alcohol. This is vodka from Laos. Yes, it works. It works. Because if there is enough ethanol, there is a competition between methanol and ethanol. And if you've got enough ethanol, there is no metabolism of methanol. It works with many other alcohol. And you see how crucial this strategy is, because it's frequent and because many people die, because diagnosis is not done or treatment is not started. So the first point, and that's the case for every kind of intoxication, including snake. First, the cornerstone is knowledge about intoxication and antidotes. The second case is this one. The first cause of death in a urban area in case of fire is trauma. Fall from height. But if they don't jump, they have smoke inhalation and cyanide poisoning. Cyanide poisoning is responsible for cytochrome oxidase blockage, and we've got an antidote. The antidote is very well known, routinely used, is hydroxycobalamin, because of the cobalt able to capture cyanide. When we have to manage patients with cyanide intoxication, antidote is indicated in case of heart failure, respiratory failure, or brain failure, usually in case of comatose patients. It has been demonstrated in animals models that the key is the timing. Look, if you are able to treat the patient immediately, there is no death. At 4 minutes, it starts to increase. At 8 minutes, it's too late. Of course, it depends on the dose, but it's really time-depending. It means that, in this case, we've got to start the antidote immediately. It means on the field. Moreover, most of these patients are severe and managed in cardiac arrest already. And then, if you don't use the antidote immediately, it will not be useful later, because the patient will be dead. So, maybe you saw these impressive pictures. It was this night in Hong Kong. Incredible, incredible. Antidote use cannot be delayed. It means that it has been to be started on the field. On the field. It will be too late in the hospital. In this case, I had to manage this patient at home. Young lady with no severe symptoms, but you can see on the electrocardiogram sinoatrial block that we can, with this ST depression, scooped ST depression, we can say that it's probably due to digoxin. This is the U waves. And then we say digoxin poisoning. These symptoms and final outcome is known since few years, you see. Antidote is also known. It has been used for the first time in '76. And in the recent guidelines, there is an indication of treatment in these old patients, just because bradycardia and conduction disturbance, it should be started immediately, because if it's not the case, we know what happened. Cardiac arrest with asystole, or cardiac arrest with ventricular fibrillation, and if, by chance, there is not cardiac arrest, you open the door to multiple organ failure because of the time without good blood flow. It means that this treatment should be started immediately. And this patient is the first patient we treat with antibodies at home. So, what is the difference between these two cases? In both cases, antidote has to be started immediately on the field, out of the hospital, in pre-hospital setting. The problem is that, and the difference is that, in one case it's frequent, in the other it's not frequent. And the second point is that in one case it's very, very expensive, in the other one it's expensive. It means that you've got to have a reflection, a discussion, and a choice about the strategy to manage antidote in such condition. Because antibodies, it's not only expensive. The problem is that maybe we will throw the money out of the window because you will not have the opportunity to use them. It's only 3 years. And I can tell you that when you ask pharmacy a new stock of digoxin antibodies because the other one is too old to be used and too old because you did not have the opportunity of a treatment, it's not so easy. The last case is this man. There is no sound, but they explain that it's heroin poisoning. And they start the treatment. And this is very interesting because you know that there is I said problem, but problem is probably not the good word. In the United States, it starts 15 years ago with an epidemic of death due to opiates abuse. It's so important that it's responsible for a decrease of life expectancy. Again, there is more than 100,000 deaths every year in the United States because of opiates. But there is an antidote, and even there is an antidote you can use without any infusion. There is something surprising, which is that it's a very well organized country with paramedics, with trained paramedics, with all facilities, and despite this organization, there is a lot of death due to intoxication. The reason is that in most of the cases, when paramedics team arrives, it's too late. It's not poisoning, it's cardiac arrest. And then they decided that they should give the antidote to the first responder. And this first responder can be the family and the police. usually the first on the field is the policeman. And it works. You can see that more than 50% of the patients who received the antidote from the policeman. And I like this example because everything is supposed to be well organized, but you see that it doesn't work in a specific condition. Managing intoxication is managing antidote availability. You know that in France, emergency system is based on one phone number, 15. Emergency medical system with 2 or 3 particularities. The first one is that in every case, you will speak with an emergency physician. The second one is that, depending on the situation, we can send fire brigade, we can send light ambulance, but we can also send mobile intensive care unit. And this mobile intensive care unit is a team with an emergency physician. It means that we've got emergency physician in the dispatching center and in the ambulance. The aim is to be able to do in the ambulance or at home everything that we can do in the intensive care unit. And it includes orientation of the patient. In the case of intoxication, it means the good patient at the good place, in the good bed, in the good unit, in the good hospital, at the good time. And it means that we have to be able to start immediately the treatment, including treatment with antidotes. So we've got to have a reflection and a strategy about the management of antidote in pre-hospital setting. We are working on this question since 20 years, saying that it was a part of the conclusion of the previous presentation. It's the job, the ethic of the emergency physician to be able to treat the patient with the best treatment if this treatment is available. And moreover, you can see that it's not only ethic, it seems to be legal. But it's not so easy, because the first question is, there is a long list of antidotes. Some of them are frequently used, and some of them are rarely used. I don't want to detail this discussion, but you can see that there is a discussion about what kind of antidotes where, depending on the expected benefit of the acceptable delay and probably the cost. We had last week a long discussion with the pharmacy in the hospital because I wanted to have antibody idarucizumab for dabigatran, which is a new anticoagulant. It's very expensive. Yes, it's very expensive, but it has been demonstrated that it was useful, efficient in case of bleeding. And where we've got to manage a bleeding patient under dabigatran, we need this treatment. We need this treatment, and like the others, it has to be started immediately, as soon as we've got the diagnostic. So, after a long discussion, that's okay, we've got it. In contrast, you know that in mainland France, it means when I don't speak about Guyana and Martinique, there is no snakebite in France. Paris is not so tropical. So in contrast, we don't have antivenom in the pharmacy. But that's not enough. The second problem is to have antidote available at every time of the day, every day of the week. The question is, where do we put the stock of antidotes? Who will be able to transport them regardless of the time? So we had to decide among this strategy. First, antidotes in the ambulance. It means immediately available on the field. Antidotes available in the hospital. But in this case, where? It can be, where are the ambulance? We've got only one treatment that we share, finally. It can be in the ED, in the intensive care unit, or in the pharmacy of the hospital. But it can be elsewhere. For example, in the poison center. And sometimes it's not in my district, it's not in my region. Maybe it's not in my country. But we've got to anticipate and to know where to find it. So this is Paris, and this is the district I'm coming from. This is the hospital with the SAMU, dispatching center. We've got 4 big hospitals, 5 small hospitals, including private clinics, 5 hospitals with mobile intensive care units, and together we decided some of the antidotes are in the ambulance, some of them are in my hospital. In my hospital, not in the pharmacy of the hospital, not in the ED, not in the intensive care unit, in the pharmacy of the SAMU, immediately available for us. The aim is to be able to bring them at home, if necessary, or in another hospital. And I take this example of another hospital because one of really unexpected problem is 2 administration. The administration of one hospital, the administration of the other hospital, who will pay the antidote. If we go back to the snake, the problem is similar because we saw that in many cases there is the antivenom and it's not used. This is why I was very interested in your impressive presentation, because it's exactly the reflection we had during the last 20 years, how to make antidotes immediately available for the patient. So the question is not, do we have an antidote or not? It is the antidote available, and more, is the antidote immediately available. And this is the challenge for me daily, but for you also. Thank you.
Thank you very much for your presentation. We have time for questions before we finish the activity of today. Yes.
Thank you, Frédéric, for this excellent presentation. So, after listening to you, my reflection is that you brought the problem from a medical, scientific, and ethical issue to a political and medico-legal issue. And I think that now the time has come to that politics take their responsibility to listen to us and to make the antivenom available in, I speak about France mainly, because the regulation in France is very difficult for products or antivenoms which are delivered under a compassionate use. We cannot bring them out of the hospital. So what do you think about that?
Yes, I'm afraid the administration will be much more sensitive to the medico-legal issue than to the ethics issue. But I had this slide, but it was not at the big, when we started to organize this antidote availability, the aim was ethic. And you're right, part of the problem for antidote, including antivenom, is scientific. We've got to obtain antidotes. And the other one is politic, ethic, but also scientific, because we've got to demonstrate that it's useful for the patient, as they did in the previous lecture. So we've got to be involved in the discussion. It cannot be only politic. It's scientific, pushing the politics, pushing strongly.
Well, thank you very much to all the speakers and all the audience for an excellent day of excellent presentations. And now, on behalf of the University of Costa Rica and Instituto Clodomiro Picada, we invite all of you to a welcome reception that we have in the same place where we had the coffee break this morning. And we hope to see you tomorrow at Instituto Clodomiro Picado for the second day of this workshop. Thank you very much.